All right, welcome everyone. This is Bright Spots in Healthcare. My name is Eric Glazer. Our show is produced by Bright Spots Ventures. Each episode, we bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospital systems, medical groups, other healthcare organizations around the land, because our goal is to identify as many of these bright spots as possible so you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If this is your first time joining us, welcome. Thank you for listening or tuning in live via webinar. If you're here via Zoom, I suggest to everyone, if you want access to some of the great guests, like the ones you see before you today and all of our past guests, we're talking about innovative ways that they are actually improving healthcare for everyone. Please subscribe to Bright Spots in Healthcare. You could find that on YouTube or anywhere you subscribe to the podcast, Spotify, Apple, Amazon, you name it. Just type in Bright Spots in Healthcare and you will find us. Today's sponsor and partner in crime is Navina. We're excited to have them as a partner. They are an AI co-pilot that transforms the way clinicians interact with patient data so that they can truly understand every patient and deliver the best possible care. You're going to learn more about them later on in the show, but if you want to check them out right now, you can visit them at navina.ai. All right, we have a lot to cover today. Incredible topic, lots of cool things. I've prepped with all of these guests you see before you, and I know there's a lot of great bright spots and strategies that you are going to hear about today. The title of this episode is The New Physician Playbook, and we're going to specifically be talking about AI workflows and value-based care in action. We're going to talk about some of the value-based care tactics and technologies in AI, but we're also going to be talking about the strategy to enable your organization to be most successful when adopting new technologies, especially all of the hype, some of it very warranted, around artificial intelligence and machine learning. We do have a Q&A module, as our regulars know. We're going to be really tight on time. You see, we have 5 guests today. I will introduce them as I bring them onto the show. You could ask them questions to the Q&A module. We may not get to each one today. It's just going to be really jam-packed. It's just a forewarning for everyone. Also, in about 40 minutes, I'm going to send you a survey through SurveyMonkey through email. Yeah, that's another email from me. Chalk one up, another one up for me. We ask you the favor of taking 2 to 3 minutes to give us your feedback. We use this to direct our programming throughout the year and just help us make us a little bit better. We've been doing the show for over 11 years, and your feedback after each episode helps us provide a little bit more value to you and your peers each and every episode. So we thank you in advance. And in fact, I'll be taking good notes on a Google Doc during this episode. And if you complete the survey, I'll just send you my notes. They're not pretty, but I'm pretty thorough. So you'll get all the notes from today's episode if, in fact, you take the time to give us those 2 or 3 minutes of feedback towards the end. All right, we're going to get started here. I want to start with Dana McCauley. She's the Vice President of Value-Based Care at Navina. And Dana, I actually want you to sort of take off your Navina uniform for a moment and bring in your old uniform when you used to be in a leadership role at Millennium Physician Group. And I want you to take us through the moment Millennium Physician Group knew it needed to overhaul its risk adjustment process, and how your team went from sort of failing with new technology to creating a scalable, successful technology with AI. Just take us through that whole story to get us started.
Yeah, thank you for having me, Eric, and it's a pleasure to work alongside these amazing peers today on the panel. The primary care is near and dear to my heart. I spent 10 years at Millennium Physician Group. I ended up leaving in 2022 so that I can really transform healthcare across the United States. I was responsible for 800 providers. I had 650,000 patient lives. 230,000 of those patients were in some sort of VBC contract across our 150 plus locations in Florida and Texas. Some of the challenges that I had is, as we were taking on these value-based care arrangements, I needed to simplify to all of the providers and staff, like what does it mean to be involved in value-based care? Why is risk adjustment so important? And so we started a prospective coding process, and I had a prospecting team that was touching the patient's charts prior to them presenting to the clinicians. And we were frankly overwhelmed, right? When we started doing this 10 or 12 years ago, there was no infrastructure in place. There was no systems in place. We were using like old-fashioned yellow sticky notes. We ended up being really good. We got the process down, but in 1 year alone, Millennium Physician Group acquired or onboarded 240 new clinical providers. When we acquired them, they also brought their panel size. So when you bring your panel size into an organization, it sometimes dilutes all of the awesome work that you and your teams have been doing. Um, I had a very successful, highly productive coding team, CDI team. They were touching 40 charts a day, but that still wasn't even enough, right? I wanted every single patient chart to be reviewed at every single time we had an encounter, frankly. I partnered with a handful of vendors, and unfortunately, after I signed the contracts, as many of you know in healthcare, it does not ever play out the way that you think that it did. And so, um, we we partnered with a partner that stated that they had artificial intelligence on their roadmap, but they did not. And I knew that we needed to have AI in order to scale at the level that we were looking to do. One of the pilots lasted a year. The other one was 4.5 years. And unfortunately, we had to seek another solution. In that time frame, I was still having to hire human capital to help us get through the medical charts, which you all know, these experts cost a lot of money, right? By the time you onboard them, by the time you train them, then things change in CMS, right? You have to reflank and re-educate. We ended up losing, I think, millions of dollars in just human capital expenses alone. So I found an AI solution that I was allowed to bring my 600 primary care physicians alive in a week and a half with minimal training. I had to train a trainer model. We had 15 education sessions that were live and recorded, and I was able to do that training for our physicians in about 45 minutes or so. And then the Navina dashboard allowed us to track progress and onboarding. This is probably one of the most successful rollouts that I've ever done in my 28-year career history. I was very concerned about taking a whole entire organization live using artificial intelligence in a week and a half. But 10 out of 10, Eric, I would do it over and over again. Like I said, the best case scenario for everything that happened for our organization. Fun fact, the majority, I think we had 15 different risk contracts. Most of them ended up going to full risk contracts in the last year that I was there, and the majority of them were very successful. So thank you for allowing me to share the story.
That's great. And you ended up obviously going to work for Navina after it. Could you just take us very quickly through what were some of the key things? You mentioned the training. So was it, did you create that training process? Was it a collaboration between you and your partner Navina at the time? That seems that train the trainer model seems to be the key to smooth implementation.
Yeah, that's a really good question. So what Navina does is it allows providers to be clinicians. It allows them to focus on what does the patient have? What are we trying to solve for? We take all of the guesswork away for providers having to be coders. Basically, Navina was serving up the clinical evidence either to my CDI team and or to the physician saying, hey guys, take a look at this. Do you believe that this clinical evidence is appropriate for this ICD-10 code? Once the provider or the CDI team says yes, then it automatically rolls into either the assessment and plan or the staging area for the physician. So I no longer needed to train providers on how to be ICD-10 coders. I got to allow them to focus on clinical evidence, and it really freed up the bandwidth that I think Dr. Gupta is going to speak to when rolling something out. It allowed them to be clinicians and not necessarily worry about like the nuances from an administrative perspective. The train-the-trainer model, it was pretty self-sufficient. Everybody could see the clinical evidence. You push 1 or 3 buttons, and then the magic just happens.
Right. I'm going to now bring in Dr. Brian Hoberman. He is the Executive Vice President of Information Technology and the CIO at the Permanente Federation. He's also the CIO at the Permanente Medical Group. Brian, you've helped now lead what may be the largest deployment of ambient AI scribes in U.S. healthcare, potentially, maybe unofficially. Can you take us inside a specific moment, maybe early stages, where you or your team realized this wasn't just a tech experiment, but something that was fundamentally changing how care was delivered?
Sure. Good morning. Thanks for having me here. This begins with, of course, technology evolution and the opportunity that exists because, some really smart engineering people have figured out how to do this, and it actually works. And then it leads to, in our organization, a change in leadership where we had a new CEO who recognized that there really was a need for uh, technology to help decrease burden on physicians. And the question that she asked us, and when I say us, I mean the technology leadership folks, was, what can we do? And Ambient was ready to give it a try. And she said, I'm all in, let's give it a try. So we went for a pilot with Ambient, and we've deployed it in really just a matter of weeks. And the feedback, frankly, spoke for itself. Because I've been leading healthcare IT for around 20 years, and usually the best I get when I deploy something new is silence. But in this case, I had the rare situation where I got plaudits. People were saying this is fantastic, we love it, and it was life changing. And that's what made us realize that this really was something new and something special.
And is that what, when you're thinking about how you roll something out that quickly, do you start piecemeal or do you roll it out throughout all your different locations? To take
Yeah,
us through sort of what that looked like as you.
sure. I'm gonna compress a lot of detail into kind of a compressed story, but it begins with demonstrating that the software works. And the software working is always a given. Software has to work, but with AI, there's this extra burden of making sure that it works in a responsible way. And we had to demonstrate that. So we went through a bunch of small pilot users who were extremely detail oriented, and we asked them to convince themselves that this thing was creating a note that faithfully and without hallucination, without bias, captured what they were doing, and that was actually clinically useful and that they would want in the medical record. And once we had done that, and we did that with around 40, 50 people, all of whom are kind of part of a core informatics team. And that may sound like a large number, but bear in mind that our organization has, depending upon where you count, either 10,000 physicians or 25,000 physicians. Ultimately, we rolled it out to 25,000. In the early part of the story, we're talking about 10,000. So once we got that validation, we kind of took two different paths. One path was a very formal evaluation to make sure that the thing was safe by actually checking against a transcript and making sure that there were no errors being introduced. And the other thing was starting to roll it out more broadly to clinicians, where the clinicians had a very easy opportunity to provide us with feedback if they had any concerns about it. So once we passed that threshold of, hey, this works, this is acceptable, this is good, then what we did was we relied on a existing network of physicians helping physicians that's built into the organization. And we created some job aids, we created some videos, but really training wasn't necessary. We never did classroom training. It's easy enough to use that we were able to just put it out there and get people to help people kind of shoulder to shoulder. And it took off because it was such a pleasure to use and decreased burden by so much that people who were feeling that burden were just drawn to it. And we saw very rapid adoption occur.
What were some of the other benefits you realized? Can you take us through a little bit of some of the early adopters, maybe by, because you did mention a lot of your very early adopters had an IT background in addition to their clinical role. but what about certain specialties that maybe have high burnout? How did that technology get integrated with them? How well received was it? When did you see that it was actually making a huge
Sure.
difference?
So there were two phases of that. Well, first was anecdote, and the anecdote started coming in almost immediately. I'd be hearing from our CEO that, at the board or as she visited medical centers, people would come up to her and tell her how wonderful this thing was. And why was that? Well, because docs in specialties that are heavily documentation driven spend a lot of time sitting at the keyboard. And sitting at the keyboard does two things. One, of course, is it detracts from your direct patient contact. There's a painting I saw once by a child that was her experience with the pediatrician, and instead of the doc looking at her, the doc is looking at the monitor. And so what we saw here was that the docs felt that they were having better patient contact, and we were actually hearing feedback from the patients, because we're always checking in with patients, that they felt that the visits were at least as good, if not better. So we were hearing a lot of anecdote and getting a little bit of data about the patient experience. And then a little bit later, we started seeing data come through some of the measurements we do in the EMR that showed that people actually were experiencing less time in notes activities. And that led to actually less time logged into the EMR in after work hours. So anecdote was backed up by data, and both were telling us the same story.
Anything that when you look back at this success story, I mean, I know you could give credit to AI. You could also potentially give credit to just the infrastructure and process you have put in place to implement such new technology successfully. But is there anything like in the weeds, one or two things that sort of you guys did particularly well or had in place that enabled this to be so successful so fast?
So I think that the first thing is just kind of how we lead technology in general, which is, the permanent medical groups are physician-led. And this thing, while absolutely supported by IT down the road, initially was done purely by the medical groups and the Permanente Medical Group in Northern California, and was physician-led for physicians. And so there was this tremendous kind of empathy towards what the docs needed and how to work with docs to get it done. And I think that's a key success factor in a lot of the stuff we do. We think that being clinically led is one of the hearts of what makes us successful. I think that was the first thing. The second thing, frankly, was that we had a lot of really smart people who were able to, dig into the various types of analytics that we needed to do in the beginning, and were willing to offer their time to do it. So we had the right leadership, the right spirit of collaboration, and the right skill set. And then, of course, the timing was right. The technology worked, and the climate was such that people were really hungry for something to relieve these burdens.
This is great stuff. And I know Dr. Hoberman is double booked and squeezing us in between appointments right now. So we're going to let him loose from the show in a moment. So I appreciate you kind of coming in and sharing that. You guys, this whole experience, I know not verbatim towards sort of how you just told the story, but is covered. You guys had it published in the New England Journal of Medicine Catalyst article. Just give us, right before you leave, a quick 60 seconds on what that article would cover for those who have access to New England Journal of Medicine Catalyst.
Sure. We published two articles. The first was, our very preliminary experience, and we just published another one a few weeks ago. I think the biggest headline from the new article was that there's kind of a dose response thing here. The more you use it, the less time you spend in notes. And we saw people who were actually spending more time in notes than anybody else in the med group now spending less time in notes than anybody else in the med group. And of course, that leads to happy providers, because it's not like, people waste their free time. They use their free time very wisely. And they're so now freed up to do other things that they need to do, we love that. We also, see that ambient, it obviously doesn't apply to everything. If somebody is coming in for a procedure, chances are you're not going to need ambient. So the procedural specialties will use it as they're writing H&Ps and that kind of stuff. The specialties that are more diagnostic driven may use it in every one of those visits. We're also seeing, that not every single person who is a candidate to use it has adopted it, and that, of course, is to be expected in technology. And we're now looking ourselves at kind of, well, what are the marketing, to use that term, considerations that are causing some people who would really benefit from this to resist using it, and we're trying to understand that better. That's a current frontier for us.
Great stuff. I appreciate that. Great insights. Get out of here. I don't want you to be
All right.
late. Brian Hubbard.
I appreciate you letting me hop off. Take care, everybody.
Thanks,
Bye-bye.
Brian. Really appreciate it. I'm going to bring Stanley on in the Pacific time zone and bring in Dr. Reshma Gupta. She is the Chief of Population Health and Accountable Care at UC Davis. And Reshma, success stories like we've just heard, they happen with great tools and technology, but they also, they need to have inside, and you heard Dr. Huberman talking about it, infrastructure and a process and a framework. So, hospitals, medical groups, a lot of the technologies fail because of poor product planning and implementation. Take us through how UC Davis Health approaches new technology and new solutions and new models, and how you've set yourself up to be successful.
Yeah, no, thank you for having me, and great question. We've spent a lot of time thinking about this, and in my role, especially in population health, it was almost the instigation of thinking through a new framework that didn't exist that we needed to develop for ourselves. As we were looking around, we realized there's nothing out there actually. We've got to just start this. So we started a journey around 2021, 2022, and we had an initial project, focus area that we were working on, but we realized that in population health, especially, I think is in so many different areas of the medical centers, we have so much need for AI. So one reason, just as background, is a lot of the work that we do in population health is we identify our patient population and we try to be proactive. We need to know what may happen in the future and then be able to provide services to them in a proactive way through registries and things of that sort. So you can imagine so many different areas where AI potentially would be helpful in different forms. So our team was ready to really jump into AI predictive models, and really wanting to kind of scale them, deploy them across the institution. But we realized we faced a number of barriers, just like you mentioned, how to make implementation smooth, how to get buy-in from the different teams that would be using them, how to change practices or tools that they were already using, and then really build trust both with patients and then the care teams. So the initial kind of project that we were working on is something that nearly all population health programs need, which is specifically building an AI risk model for a patient population to identify who might be at future risk of a hospitalization or ED visit over some time frame, and ours was about 12 months. And then it's very important because by identifying that, we can deploy social workers, care managers, do needs assessments for patients. Especially with patients with really complex needs, our programs really wanted this predictive model to determine which patients are most in need to deploy those scarce resources. So our teams had a lot of concerns, though. One of the biggest concerns, and this is a part of our framework, is talking with the clinicians, talking with the care teams to figure out what those are from the beginning. And it was the shiny tool. They were very afraid that the system would start grabbing a shiny tool and then try to find a program to build around it, instead of actually starting with a problem, right, that the care teams, patients are having, and then really think about how can the tools, the technologies, the products scale that, make it more efficient and have really clear outcomes around that. And the other thing is they had a lot of concerns around transparency, about how this process would happen, communication around it, and barriers around trust. The biggest thing that came from our care teams was that some of these models, without having a lot of transparency, might be leaving patients behind, leaving patients out, causing harm that they really didn't want to do. So what I did is I reached out to our IT AI specialists, and I also reached out to our equity specialists here, and the folks were clinicians themselves, and then they also led teams, and I think that brought in a different kind of framing to how we wanted to start working together. And we set out to create a new custom AI predictive model locally, evaluate it, track it, monitor it, have an oversight system, and really develop a framework. So we develop a framework, and it's actually called Be Fair. So it stands for Bias Reduction Equity Framework for assessing, implementing, and redesigning healthcare. A little bit easier to just say be fair for risk models. But essentially what it is it's a like soup to nuts approach that when you have a problem, it's kind of a 9-step framework to walk you through how to think about it, how to get the right people in the room, and like I said, monitor and track it over time. Bias can come up all over the place. We have patients that are small patient populations. We have missing data for certain patient populations. We don't always monitor these risk models over time, and our patient populations change. And so groups can get left out if we're not really transparent and have a monitoring system for it. So we invested in developing the framework because we thought we'll use it in this situation. And then as we grow, as we use new models, we can use the same one. And we ultimately found multiple areas where the model wasn't performing as well. But this process helped us identify areas to mitigate and to improve that and close those gaps.
Could you quickly talk about where the models weren't as effective, how you identified that, and what immediately you did about it?
Yeah, so part of that framework is even after developing the model, evaluating it. And I think so many of us, may not have our own AI teams to build our custom, models. And so we also use vendor-based ones. But the thing that's unique is how do we evaluate it on our local population? And not just overall, but stratifying it and disaggregating the data by, different demographics, different populations. And we definitely found that populations that were smaller, it didn't perform as well. So we had a smaller community of by race ethnicity, we had smaller communities with certain chronic conditions. And because of that, we realized that it didn't perform as well. And so it helped us as we were kind of digging into reasons why. And that's why having that kind of group working together can build out that context, especially with our equity team and the clinicians. We figured actually there's a lot of missing data for some of our patients. So some of our patients have a lot of challenges with like cognition and memory. And what we realized is a lot of the data points were not there on intake. And so we had to really train our staff in raw data collection to make sure we do a better job of getting that data for them. Another area was we have a cutoff. So if our care managers see that a patient has a certain percentage or higher risk of a future hospitalization, they'll reach out. But if we set that threshold too high, like at 85% or higher, there's more bias. Certain groups are left out, and we lower that threshold to 60%. That difference really, really reduces. And so we changed our operations in our outreach to patients to try to reduce that. And that all came from kind of just being transparent about it.
It's great. I want to stay on framework and enabling for success, and we're going to start showing examples of different AI tools in action, because I just think it's so important that everyone's thinking strategically when they're even going out there and they're pitching their team, their board, their boss with new approaches, that they need to have the framework to enable success. So at UNC Health, now going to the East Coast, they have a similar approach, but different. And I want to bring in Ram Rimal. He is the manager of data science engineering at UNC Health. And Ram, could you help us understand some of the lines of questions that we should be asking before we jump into anything big, anything AI, so that we're ensuring that we're picking the right projects?
Yeah, thank you so much, Eric. And Resma, in UNC Health, we have also something called Responsible AI Framework. And I have a privilege of leading AI team in UNC Health. And when we get this question, we have a two-line of thought. Number one is called Responsible AI side. Another is value side. So that's the reason we call value-based responsible AI. And AI part, responsible AI part, have similar thing like what Resma was talking about. For the value part, Eric, the part you are focusing on, we have generally let's take one example. Yes, when somebody comes to me, because there are a lot of problems to be solved in healthcare. When I hear a problem in healthcare, when somebody reaches back to me, in my mind, I have a 10-question assessment in general. We ask that question to our stakeholder. Let's talk about 4 of those questions and how that helps me to make the decision. For us, number one question is, so what? Yes. What is the impact? For us, everything needs to be centered around patient or patient care. If somebody can tell me what, so what, and the next question I ask is, what does success look like for you? Like, what does success mean? Because that helps me in my mind to frame up like what is their expectation, where are they coming from, so that when we give this product to you, you feel as satisfied as you thought when you're bringing the product. And the third piece is, how do you want this model or any algorithm, anything like that? The way how I ask is like, I know your crowd knows, Eric, like about our EHR problems. If you ask me to integrate something in Epic or Cerner versus you said, I'm happy with a refreshable dashboard every day outside of Epic in like, I don't know, Tableau or Power BI, that's a totally different calculation for me. And I hope your audience understand that complexity there. And when I ask those questions, and then the last piece I think I ask part of the evaluation is, how are you doing it right now? Because sometimes people want, like as Resma was talking about, fancy solution. If we understand their current process, we might be able to make this process a little bit better as we are building something better and nicer. So those 4 main questions, and in addition to other 6 questions, help me to decide, should we go really quick and fail and fast, or should we go slow and big?
Let me repeat some of that stuff back to you, see if I was taking good notes here. So value-based responsible AI is sort of the methodology that UNC Health uses, right? Did I catch that correctly?
Yes.
And then the 4 questions of the 10 that you shared with us is, and some of these are my words, but I think I'm interpreting them actually accurately. Why is this important? What is the impact of solving this problem? So that's the first question you ask. The second you would ask is, okay, well, what does success look like?
Yeah.
The third is, what is the impact of solving this problem or the return on value? And then I think you said it, and maybe I'm putting words in your mouth. How do you want it to be used or integrated? How do you want it? I think in your prep call, our prep call, you said, how do you want it to be in your hand? So
Yeah,
you want a dashboard.
Yeah. How would you want in your hand? Because if you want this to be integrated in Epic, I need to think about 10 different teams. I need to get how many different teams I need to get involved. But if you say I am happy with one dashboard, which refreshes once a week, once a day, I need to have that different calculation on how I'm going to deliver that product in your hand. So
Exactly.
that is going to be really helpful.
And then the fourth question is, how are you doing this right now to make sure that we know that the approach right now isn't as effective as what we can be doing?
And then can we give you a very small win as we are building the big product? Yes, because sometimes people think AI is a solution, and sometimes just automating some of their workflow might give them what they want.
Great. All right, we're at the halfway mark, a little bit over, a little bit behind schedule. We're going to catch up here in the air. And we're going to start sharing some now examples of AI in action. Before we do that, I told folks at the beginning of the show, we have a great new partner in Navina in the Bright Spots family. Happy to have them. I want to tell you a little bit more about them. I mentioned they are clinician first AI co-pilot for value-based care. Well, recently they were named best in class, KLAS, for those of you following along, for clinician digital workflows. They turn fragmented patient data into actionable clinical insights right at the point of care. They natively integrate into clinical workflows. You've heard that mentioned a number of times by our guests so far, as far as enabling for success, fitting into workflows. Their AI co-pilot helps improve risk adjustment, quality metrics, and population health while significantly easing the administration burden. They have earned the trust of more than 10,000 clinicians and care team members across 1,300 clinics from some of the leading value-based care organizations in the country, like Privia, Agilon, and Millennium Physicians Group, who we heard a lot about. So check them out on the web. If you want to meet Dana and learn a little bit more about what she's doing, pick her brain. We'll put a survey out. That survey, that feedback form, you could click yes that you want an introduction, and I'll personally introduce you to her. Also, if that's not enough proof, the American Academy of Family Physicians, AAFP, they conducted an independent study of Navina's technology across clinics with 1,800 providers and nearly 700,000 patient encounters. And the study found that physicians who used the tool, the AI tool that Navina provides, they had a 30% reduction in chart review burden, 23% less burnout, and 84% acceptance rate. If you want to take a look at this AAFP article and study, I'll send it to you. It's 13 pages, mostly big charts. I like saying USA Today, like visuals. It's a really interesting read if you want to get a sense or help build your business case as you're thinking about new technology implementation projects at your organization. All right, let's bring in Dr. Eric Penniman. He is the Executive Medical Director at Summit Medical Group. We're bringing him in. He's the voted best 6th man on podcasts for 2 years running now. Eric, thanks for being here. Chart prep has long been a pain point in risk adjustment and quality programs. What was the problem you were trying to solve at Summit, and how did your approach to improving chart prep evolve over time with or without AI?
Well, I'll begin without, because I've been here at Summit for about 9 years, and Summit's a primary care organization that's very committed to value-based care, especially in the Medicare Advantage and Medicare space, and we're at risk in all of those areas there. And so we are really tuned in, and we're a physician-owned, physician-led organization. So fortunately, our physicians are also very tuned into this. And so we have over time built up a risk adjustment coding department of about 20 people who've done a wonderful job in prepping charts and identifying, because we're only a primary care group, hospital records, especially records, often aren't in our EHR. And so we were oftentimes going blind. And so our risk adjustment coders were finding documents through our local HIE that we would use and do the best they could to identify some of the important diagnoses that we needed to know about to manage, as well as then from a coding perspective and succeeding in our value-based care contract. So that was the first 8 years that I've been here. But we continue to grow. We're rapidly growing in Tennessee. We're up to 520 providers. We have 500,000 patients that we manage, and our staff is just not able to totally catch up. So we need to accelerate, and we need added efficiency. And so in the past couple of years, I've really been tuned in and watching what AI is bringing to healthcare and the promise of that. And we'll talk about another one a little bit later. But so we're currently piloting with a big number of docs and nurse practitioners and PAs, Navina, the chart prep tool that we were just talking about, just because I felt that this was essential for us to do. We needed to be able to do this and bring this to docs. As a chief medical officer, having been a family doc for 30 years, my motto is we have to make it easy to do the right thing. And so docs are overwhelmed, primary care docs are overwhelmed. There's so many things coming in at them. And so we've got to kind of boil the ocean for them and make it easy to do the right thing. And that's exactly what Navina has done. So it's been a really good initial 3 months here that we've been using it, and we're seeing just really great success.
All right, and this is all, obviously you're tying the business case here to probably improved efficiencies, probably stars, but I don't want to put words in your mouth.
Yep. Yeah. So the metrics that we're looking to improve is improve our overall RAF score, which will improve our reimbursement on the Medicare Advantage and the Medicare side. And then it's also, because it's connected to 3 different national HIEs, it's finding documents we didn't know about. So from a quality of care standpoint, we're better able to take that into account when caring for patients. But it's also, it's finding mammograms from Kentucky, it's finding colonoscopies from different states, and it's closing quality gaps. So it's helping us with our star metrics as well. So from a standpoint of those 2 really important aspects, we've been very impressed so far and how well it's going.
How has it impacted job satisfaction, or is that a value?
Yeah, the job satisfaction, once again, the easier you make it to do the right thing, the more excited docs are about the fact that they can go into the exam room and do what they enjoy most, which is just treating the patient and being focused on the patient. And so job satisfaction has definitely gone up. And we have done some initial surveys showing that docs are enjoying this tool more and more. And now we're at about a 90% daily utilization rate for the tool. And so, which I'm thrilled about, as Dr. Hoberman was talking about, oftentimes you always have those that are very reluctant when it comes to a new digital tool. And so for me to be at 90%, I'm pretty thrilled with that.
That's awesome. So you're looking at overall RAV score, obviously star ratings potentially down the road. you're looking at overall improvements in just workflow and efficiencies, and also it's, you know, how doctors are satisfied. It could actually be potentially a recruitment tool for you down the road.
Absolutely. Yeah. Yeah. We've been very successful recruiting, and we continue to try to push the envelope to make it easier and more effective to practice primary care, which helps us out in the value space, as well as just growing our patient panels, which of course in the fee for service world helps out as well. So yeah, it's all very important to success.
I know you have another story with AI that started off as a failure and became a massive success. I want to bring you right in just a moment and have you share that series of stories. That's a great one. Before we do that, let's bring in Dr. Reshma Gupta over from UC Davis back in. You know, Reshma, how did your team approach the challenge of integrating a new high risk model into clinical workflows? Let's talk about how things didn't work at first, how you responded to the feedback. You know, I alluded that Eric's going to have a similar kind of story. I do think, you know, things often don't work right away. And even if there's a great success, implementation is often rocky. So how did you respond, see what was going on, revamp, and ultimately make the model successful for your high risk?
Yeah, that's a really good question. I feel like that's the life of all of us now as we're jumping in this space.
Wow.
So I kind of mentioned before, one of the first steps was just understanding what the barriers are. So when we were building that AI risk model for population health, one of the next steps we wanted to take is to expand it and to be able to broaden it out of primary care, go into specialty, high-risk specialty care. There's various teams that look at who are high-risk patients in the inpatient setting and in the ED. So a lot of different clinicians try to, you know, that have existing tools that they use, but may not have had the same kind of transparency that we had built in that framework. And so it's, you know, what's wrong with what we're doing? You're giving us more work. It was, you know, one major thing that we were hearing. And then some of what I mentioned before, just around that, you know, using a tool that we had homegrown. How do we know it's better? You know, the buy-in and the trust, that transparency, the oversight, the same issues, right? Just kind of repeating itself. So our situation, one of them was in the emergency department, and you know, we are at UC Davis Health, but we also work across all the UC campuses and coordinating a lot of efforts across all of our health campuses. And it's a very similar issue that kept coming up where they were using our EHR vendor-based AI model, but they had used it because it was right there and ready, but it had never been tested on our local patients. So what we started kind of just hearing what their concerns were and said, let's bring this framework, let's bring a new process to this that brings that transparency. But two, let's have data drive it. So let's use the model, the tool that you're using, understand that workflow, understand how well it works on our patients. But let's do a head-to-head. Right? Let's also use the new one and let's just compare what the data tells us. And I think that just the fact we were investing, we were talking, we were being transparent around it, there's a method around it, it created a huge amount of change. The workflow in itself wasn't dramatically going to change. They had a workflow that they were using, the AI risk model, and all we were going to do is kind of insert a better performing one that was less likely to create, you know, risk and bias to the patients. And so that was, I think, one of the biggest one that made a big change. And then ultimately, when we did a head-to-head, it was a pretty significant difference. The initial model we used was like almost flipping a coin if it was correctly identifying the right patients. So when we kind of framed it in a clinical sense to say, you have all this staff that we're deploying to do some workflows, to do outreach based on this model, but like half the patients you're reaching out to aren't the right ones, and we're missing some potentially. Wouldn't, you know, even a little bit of an increase in the performance of a model can make your staff deployment more likely to get the outcome you want. That made sense to people, you know. So I think it's that communication point and making it real for them in terms of value, you know, return on health, return on investment, all of those kind of terms that we throw around.
So you had to do, I mean, ongoing selling and influencing throughout this. Can you take us through like how that all worked? I mean, how are you able, and obviously it must have helped that you have an MD next to your name as well. How did you win them over with data? And
Yeah. Part of it is it is that framework that I mentioned, but part of it it's a simple few key things that really sold it. We had started in a place where we had a need and there was already buy-in to get it out the door, which was that initial population health work. So we had data to start with that we kind of similar to the last story that was recommended. As people started hearing positive things about it, they were a little bit more open, at least to meet with us. And then we listened and kind of heard their concerns. But I think the difference, honestly, is we were really bridging silos. So we're not one group kind of in one corner of the institution, knocking on their door, trying to get in, through the back window. We're coming in with a health system leader that kind of works across different venues of care and population health, with someone in IT, with someone in equity and community. And so you have three leaders that have a clinical background, all being able to understand the context of what they're saying. And so they felt like they were better heard. And then the data, because we've got those experts in the room, the interpretation of the data, how to explain it, was a lot easier. And so that trust was, developed from that point. And it wasn't saying, we're going to force you to do this. It was very much a conversation, but the data spoke for itself.
Got it. So what I'm hearing is, and we've heard this from Brian and some others, get a cross-functional team, but make sure they're all doctors or clinicians at least. Use data to further your argument, and probably use those questions that Rami talked about as well. And all of a sudden, you've got an approach where you could, over time, win people over and make the pragmatic choice to move forward. And when you do, win them over. And I want to bring back in Eric Penniman, again, at Summit Medical Group. Eric, you have a similar story. Why don't you share that and what you were trying to accomplish and some of the setbacks you had at the beginning?
Yeah, so I'm going to go backwards about a year, and similar to Dr. Hoberman, identified that our physicians were feeling beat down, that they're feeling burdened. We know that the burnout rates in primary care in the 50 to 60% rate, and that's just not great from a productivity standpoint, from a quality of care standpoint, and overall health of our providers. And so we knew that we needed to find something to unburden them. And so when we learned more and more about the ambient AI, we initiated with one that transitioned from another product we were using. And it had initial mild success where within about 2 months, we grew from 0 users to about 40 users. And keep in mind, we have 520 providers. So, but then we plateaued at 40 users. And the reason for that is this particular AI product, while it worked like it said it would, it was not deeply integrated into Athena. So then there was a lot of copying and pasting of the notes into the EHR, which was just another clerical, mindless task that, once again, takes away the joy of medicine, and it reduced the efficiency of it. So now that product had promised that they would get it integrated into Athena, but after they continued to miss their deadlines that they had given us, then we looked elsewhere. So then actually in August is when we began looking elsewhere and found a new product. And it was pretty impressive. And I had on my pilot users for that product, people that were using the older product. And I asked them how effective they thought it was. And they thought, boy, this will be a great improvement. So I actually negotiated with the company to launch a free 1-month trial for up to 150 users. And so we launched in 3 months, we went from 0 to 360 users. Similar to what Dr. Hoberman was saying, honestly, I loved reading my email. All of a sudden I was a hero, and everybody sending me these grateful emails, and, so grateful. Some were, thanking me. Their family life has turned around. One of my favorite quotes was from one of my good friends, who's one of our lead physicians. He says, "Eric, had I had this technology 10 years ago, I'd have 10 kids rather than 5 kids." Meaning he now has time to spend with his wife, so which is our goal. We want our folks to enjoy their family lives, enjoy their families. So it's been huge, and the success and the spread of it has been just amazing. And so now we're continuing to look, okay, what are the other different products we could look at to further improve efficiency? And I've got a list of them.
That's great. I want to hear a couple more good stories. Folks, real quick, we have a number of great live episodes coming up in the month of May that we wanted to mark a calendar on. And in fact, if you want to attend any of these, we'll register you for you, so you don't have to register again. We've got an episode coming up on May 8th. It's a half-day virtual healthcare engagement virtual summit, empowering providers and enabling consumers. Super excited about that one. There'll be a half day, lots of great guests. I'll be moderating a good portion of it. We're also going to have an episode on May 15th. By the way, that first episode we're doing in partnership with Care, and just super excited. We've done it before. It's a great program. We get some great guests. Thursday, May 15th, again, live 12 to 1, typical bright spots, recording, transforming Part D changes into opportunities for member value. And then on the 22nd, we're going to talk more about AI, physician-led AI in specialty care across Medicare Advantage. All 3 episodes going to be great. Hopefully you could join us live. And if you want us to register you, we will. Dana, let's come back to you, Dana McCauley, VP of Value-Based Care at Navina. What did it take to turn, these processes around data heavy quality and risk adjustment into something scalable and successful when you're talking about big organizations? I know we were talking about Millennium earlier. I know they work with WellMed. Take us through sort of the problem and your approach to sort of overcoming it, and how all that worked.
Yeah, so I think what Dr. Gupta mentioned, right, there was no framework in place. When we were trying to set up these programs, there was like, who were you going to ask? There was no experts. The vendors hadn't even come up with solutions yet. And so I think for a lot of us that started in VBC more than a decade ago, we were scrambling and we had no other choice but to design our own stuff, right? Which is really a Band-Aid. It wasn't efficient. It worked, right? It did its job, but there was a huge amount of human capital that was thrown at that to make that successful. One of the challenges in value-based care, and Dr. Gupta, I would love to talk to you more about BFAIR. I think that's fantastic, and I'm looking to get involved in predictive modeling to help with utilization costs long-term. So you've got the risk adjustment, you've got the utilization, but then there's this other quality component, right? The only way that you can truly be successful in a VBC or a population health contract is by maximizing and try to getting as close to the 5-star goal as possible. Anybody that's been in quality knows that it sounds a lot easier than it actually is, right? You've got huge data delays. You've got inconsistencies amongst health plans. You're trying to stream and roll out processes across 150 plus locations. And so what we were trying to build internally was, I need to take the care gap files every single month from WellMed, United, Aetna, whoever. I need my team to work them, manually going through every single chart, opening it one by one. And by the time they get through that health plan care gap, I get another one that's updated with, maybe it has the claims data information incorporated. Maybe it's got my quality team notes incorporated as well. It was extremely labor intensive. So I went to Navina when I was on the provider side of the house, and I said, hey guys, can you help me? Can you leverage your artificial intelligence to scan through the medical records? And that's kind of what Dr. Penniman was alluding to. So every single month, all of our provider groups, they send us their care gap files directly from the payer. The artificial intelligence scans over those medical records, and it will automatically find all of the care gaps that we believe are closed that nobody knows about. It is life-changing, right? Normally, it would take coders a month to go through 20,000 medical records one by one, but the AI will review those charts in 5 minutes and send the information back to the coding team or the quality team or the provider saying, hey, the artificial intelligence reviewed these 20,000 patient records, but by the way, there's 5,000 of them that are found in your system. They're not documented or labeled correctly. It was labeled as a free text, so nobody knows that it's there. And we really allow the providers and quality team and coders to focus on true patient outcomes. I do not want my team of highly skilled clinicians focusing on how they're going to document a mammogram, right? I want them making sure that the patients are getting the mammogram and that we are doing preventative medicine, that we are finding cancer at stage 1 versus stage 4. That's what's important to me, and that's what's important to great patient outcomes. And so again, artificial intelligence for the win. It really, really is transforming healthcare across the country.
You alluded a little bit to Dr. Hoberman's kind of example earlier on in the show. If you were going to create a blueprint for successful implementation of AI for value-based care, do you subscribe to what Dr. Gupta, what Ram Ramal has been saying, And what would you add on? Like, just create a blueprint for us. And we're being Navina agnostic, but like, you've seen implementation across multiple organizations. You've probably seen some go well and some go maybe not as well. What would be the blueprint for you that you would have everyone subscribe to?
Yeah, when I'm evaluating any software application, my number one question is this a tool that a physician would want to actually use? And is it so intuitive that they would be willing to adopt it without me saying anything? And if the answer is yes, then let's go for it all day long. If I have any inkling that a Dr. Penniman or a Dr. Gupa or Ram would not want to use it, it's a no for me, right? There's been a lot of really great systems out there. They look great from administrative eyes, but when you actually roll it out to the clinical teams, right, they're saying, no, we're not using it. And like Dr. Penniman said, everybody wants to be a hero, right? We know when we roll failed technology out, we hear it, right? We're dreading opening up our emails. We're looking at a text message. I'm like, this doctor's going to hate me. It is a different story when you roll out something that everybody loves, right? You knew that you hit a home run when you did that. And that is truly transforming care across this country. And I think AI has the power to do so many amazing things. And we're really in the infancy of it today.
Love it. That tees us up great for our last question, Ram. I know I'm squeezing you a bit. We've only about 3 or 4 minutes left, but tell us how you decided to roll out one of your more successful AI programs and just bring it home for us with one final story.
Yeah, I think from our perspective, there are generally two approaches I would take, I think, based on my first part of the conversation. Should we go big and slow, or should we move fast and try to fail or learn fast? So there are some scenarios where we want to go big and slow. I'm assuming, Eric, your audience knows what is sepsis and why that is a problem for healthcare system. And tragically, sepsis is leading cause of mortality in the hospital for US, for UNC Health, and I am assuming that's true for everyone here if you are part of the healthcare system. And for us, like that, in that problem, my team was asked to build the predictive algorithm around ED sepsis. Can we predict who might have sepsis in ED? And we have more than 15 hospitals across the system. So that is one of the reasons to go slow, because the impact is really big. You want to get it right. And another part is thinking about resource priority. So Eric, if you want to implement any custom algorithm into Epic, or I don't know about Cerner, but in Epic, it takes more than 9 teams across the system in same pace to make that right. Because you need to think about clinical education, data governance, clinical application, data science, clinical informatics, and operational leader. That's another pillar for us. Like, who's going to work with us day to day to make sure that our clinicians are getting what is needed from the algorithm. On top of that, we build the iterative framework. So let's take a sepsis example. What happened in that case was somebody from data scientist from my team built the algorithm using 3 variables: age, sex, lactate, whether they had lactate or not. There was an iterative loop created with the ED doc so that they can give a feedback on each of those components we are adding as we are creating an algorithm. So the main reason to do that is, like, our clinician, we want them to own that project. It's not a data scientist doing a project on the side and clinician were asked to use the tool. Clinicians are part of the conversation from get-go. They would know each variable we are considering, which comes out, which goes in, so that when the model is ready, they can use it. And so that iterative framework sitting on top of impact, how big is it? What kind of infrastructure also part of the conversation, because think about rolling out across 18 different hospital systems. And resources is how we go big and slow. But there are some use cases where you can go fail fast. We had a request around the Department of Surgery coming back to us and asking, I need to understand the case length of a surgery, because if I don't know that one, it's hard for me from the multiple. I cannot overestimate and underestimate, because it's going to cost me money either way. Or like it's going to be, patient is going to wait for a very long time. In that case, we decided to fail fast. In that case, some of the framework it worked for us was somebody really interested. I call like data maverick or transformation champion. They were ready to work with us to develop an algorithm. So in that case, we created an R package, which has an algorithm implemented in one of the scheduler laptop, tested that for 3 months, That one app on the laptop became a standalone app in our Azure system. We tested that in 6 months. Now that algorithm is implemented in Epic after going through that standalone app process. So it depends on your organization. I don't know, well, what are the resources constrained, where you are in the analytical journey. Sometimes it's going big and slow is really good when you have a problem like sepsis, but you also should have pathway around going fast and fail fast and try to experiment more.
Great way of taking us home. Thank you so much for that, Ram. Thank you to all of our guests today for the preparation and for your participation. I really appreciate it. These guys worked hard. Thank you all who are listening and watching for tuning in today. We do not take the time you spend with us for granted. Sorry for going a minute over today. I do hope you take the bright spots used and shared during today's episode to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. We produce this show for you. Remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.
Thank you.
Great job, everyone. Thank you. Really appreciate it. I know we were jam-packed today. There were a few things I wanted to circle back. I ran out of time. But thank you for all of this. Would love to have you all back on. And there's so much more we could cover right now. Really appreciate it. If you need anything from us, let us know. Sherry, thank you. Sherry already jumped to our next call. Look at that. Any questions? Anything for us?
Oh, thank you. It was a
Oh,
great discussion. I kind of got lost in hearing everyone else's.
Yeah, I
work.
enjoyed hearing everybody else. So, that's great.
I learned so much, and I'm serious, Dr. Gupta. I would love to connect with you because my application will basically say, hey, Dr. Penniman, you need to look at this for consideration, which will feed your predictive modeling.
Mhm.
So I'm wondering if there's a potential partnership there. I'm just so fascinated by that. So
Yeah, always happy to connect offline. And then I think you in the chat, the link to the actual paper is in there if you want to take a look at that too. I just thought that Sherry had put that up there. I do have to
excellent.
jump to clinic
Yeah.
as I'm in a clinic office right now.
That's
And I
right.
have
You were going.
10
That's right.
a.m. patient waiting for me as we speak.
I should have given you
bless
special
us.
props. Thank you, Reshma, for doing that. Appreciate it.
Thank
Hey,
you all.
Appreciate it, Ram. Sorry you were cut off there at the end. You did great. I appreciate it. Eric, great job.
All right.
Thank you,
Thank you
everyone.
all.